Let's move on to the last case of the day. The case is going to be presented by Dr. Prince.
Prince?
Yeah.
Prince?
Yes, Dr. Prince Suchadia.
Huh? When will you become a Raja?
Not very soon.
After exam.
All three are here. दर्शन का कॉल पे होगा ना
बेचारा.
Good evening, sir. My patient is a 6-year-old, 8-year-old male child, right hand dominant, studying in 2nd standard, a case of hereditary multiple exostoses.
Studying in 2nd standard, Kashala. Just go on to your.
It's a case of hereditary multiple exostoses with restricted pronation and supination in left elbow, without any functional limitation, with parental concern of deformity. My positive finding on examination, the child appears to be constitutionally short with the
Another tantrum.
He saw this some injection or something. डर गया वो बेचारा. उधर ही बैठ जाओ.
Rishi's khazana is over.
बस. बोलो. You go ahead.
My positive finding on examination, child appears to be constitutionally short. The father side is also 4 foot 6 inches. There are multiple swellings ranging from 2 into 2 into 2 centimeters till 4 into 4 into 2 centimeter in size. In bilateral distal femur region, in left wrist region, and in the right medial border of the scapula, which are well defined, bony, fixed to the bone, moves with the movement of the limb, non-pulsatile, non-compressible, without any signs of warmth or redness over the skin, not fixed to the skin, in the submuscular plane. Coming to the
I'm listening.
elbow.
Go on. Yeah.
Coming to in the left elbow examination, the flexion extension range of motion is from 0 to 160 degree. There is restricted supination, which is 45 degree with pronation of 70 degree. The arm length is equal on both sides. The forearm length, the radius length is 2 centimeter short on the left side, and the ulnar length is 3 centimeter short on the left side. The wrist range of motion is normal. Bilateral lower limb length is bilaterally equal. There are no deformities in the knee. The range of motion of knee is from 0 to 120 degree. There are no neurovascular deficit in both lower limb and upper limbs.
So what is your diagnosis and what are you going to offer to the child?
Ma'am, my diagnosis is hereditary multiple exostoses. The other child, the other smaller girl, also having the same problem, but she's having only on the left shoulder humerus area. She's having the similar complaints. Since the child is not there are no functional limitation, so I would observe the child closely, and when the child develops a functional difficulty, then I would go ahead with surgical intervention.
What functional problems do you expect?
Yeah. What do you anticipate?
Firstly, the forearm.
There would be a restriction of supination, which would progress over the time. So the child would have difficulty in it is on a non-dominant hand. So
yes, but you can still have a limitation of bimanual activity, no?
Yes.
Then what else can happen?
What is the natural history of this deformity? How would it progress if left alone? And why do you need to observe this closely? What are the complications that can occur?
So because the ulna is short, if there is damage to the ulnar distal physis, then there could be dislocation of radius because ulna is short.
Yeah, dislocation of the radius,
which can lead to progressive cubitus valgus deformity.
And then it will be difficult to reconstruct.
Yes.
Right now.
That's at the elbow. What will you expect at the wrist when the ulna is short?
There would be dislocation of distal radioulnar joint and progressive ulnar deviation.
You don't get a dislocation of the distal radioulnar joint, you just get a progressive deviation. So if they've mainly come for the deformity of the forearm, that's how you would counsel them. If that does happen, what would you do for it? What would you recommend for it?
Since the ulna is short, I would do a gradual ulnar lengthening with radius shortening osteotomy to correct it.
Is there any other way you can control the growth at the radius?
Epiphysis.
Which would be the method that you would do? Is it possible to do 8 plates here?
Stapling.
Or
Fat into.
what about PETs? Have you heard about percutaneous? Yeah. What is the disadvantage of doing that?
There are chances of breakage of the staples and
Not really. What happens to the lengths of both the forearms if you do that?
there will be asymmetrical growth if there is, or if there is permanent damage to the growth plate. Then
So that is what you're creating, so that the ulna and the radius or the variance gets maintained and they remain symmetrical. But then it's already a challenged and shortened forearm. And then when he is only 4, right? If you do that now, even the residual growth of the arm is affected. So the younger you do it, there will be progressive asymmetry.
Okay, getting away from the wrist, what are the other problems you anticipate in at other anatomical sites?
there could be compression of the nerves. There could be fracture, bursitis, progressive deformity because of fascial damage at the knee joint, genu valgum deformity. There could be malignant
It
conversion.
can be both. There can be genu valgum, there can be genu varum.
There could be malignant conversion.
So malignant conversion, what is the rate of malignant conversion in a hereditary multiple exostosis?
So in hereditary multiple exostosis, it is around 8 to 10%. In a single osteochondroma, it is around less than 1%.
Yeah, 8 to 10%, you know, some studies do quote, but I think that is a quite a high figure.
Bit high.
Practically in practice, we don't see that much. More reasonable, you know, incidence would be around say 2 to 5%. Okay, so which are the, you know, the lesions which are more likely to undergo a malignant transformation?
Lesions which are present in the flat bones like vertebra, ribs, and scapula, they are more prone to convert into the malignant.
And flat bones,
Flat.
scapula, ribs, and
pelvis.
pelvis on the ilium. Okay, so which is the you know the malignancy that you see in the hereditary multiple exostosis?
Most common is chondrosarcoma, which is seen when there is malignant conversion.
And what are the signs?
There would if there is a sudden increase in pain, if there is sudden increase in the size of the lesion on X-ray, if there are if the lesion is ill-defined, if there is the cartilaginous cap is more than 2 centimeter, then these are the indications of a malignant conversion.
And
Specification of the cartilaginous cap.
Yes.
and how do you diagnose it on imaging?
So on X-ray, it is confirmatory. But
X-ray is confirmatory.
to look for the cartilaginous cap, I would also go for an MRI.
So what are the complications of you know, exostosis that you see in the spine?
Sir, it can lead to scoliosis.
Not really. So there is some recent literature which has said, which shows that, you know, in hereditary multiple exostosis, especially those children who additionally have exostosis around the scapula and the pelvis, they can have intravertebral, you know, exostosis, which can be within the vertebral canal and can cause myelopathy. So that is something that needs to look for. Okay, a child who comes with, you know, difficulty in walking, you know, many times it is attributed to, you know, distal lower limb problems. But in that cases, we have to be very careful with the clinical examination and look at the spine as well.
Yes.
Okay. Additionally, what problems do you anticipate in the hip joint?
Sir, if the osteochondroma is around the proximal femur region, then there would be a restriction of range of motion and difficulty in walking, stature.
And a gold medal question. What are intra-articular osteochondromas? What are they called?
And control. Sorry.
If you come to this question, you know that you are doing well. Anybody? Trevor's.
Around the ankle and the knee, usually they get that. Suppose this child was really young and parents say, we just want that swelling excised, especially the one at the radius. And you go ahead and agree. And then he's stiffer than before. What is the reason for that? Parents insist on excision of that radial osteochondroma. You agree, you go ahead and do it. And then the child is stiffer than before. Right now he has a restriction of supination. Then he gets a restriction in pronation also. He just gets stuck there. What's the reason for that?
Fibrosis of interosseous membrane, which would
So correct. So the answer is that usually the osteochondroma is larger, the involvement is bigger, and when you operate, you create more fibrosis. The other reason that can be, especially in this kind of an X-ray, is that a lot of them have a synostosis even at the proximal joint, which if they are very young, you may not actually see it. When they grow up, that's when you realize that it's just a synchondrosis, which is now ossified. So examine all these things and keep all these chota things also in mind for us.
Okay, so finally, how would you manage this child, this particular child? What would you do right now?
So I would observe them closely for progression of deformity, and then with the serial visits and X-rays, and if he develops a significant functional difficulty limitations, then I will go ahead and operate the patient.
Yeah, because I think he's too young to undergo the procedure right now. So I think a correct approach would be just, observing for the present moment of time, keep a close watch, but
And
warn
family
the parents,
counseling.
Yeah, warn the parents that, regular follow-up is necessary because he may develop complications which would require intervention subsequently.
Any last question from famous last words?